Our next session will be on leveraging innovation to drive value, and we're going to get into some terrific issues around technology and privacy and how it all pulls together. So please join me in welcoming our moderator, Sung-Hee Choe, who is a director at FasterCures, where she focuses on ways to create pathways for biomedical innovation, and she'll introduce our panel. Thanks, Sung-Hee.
Thank you. Good morning and welcome. Again, my name is Sung-Hee Choe, and I'm a director with FasterCures, and I am delighted to be here to moderate this panel discussion to discuss some of the exciting developments in digital health and the changes that we expect and some sort of outlook for the environment. And so we are very fortunate to have here today multiple perspectives represented. We've got the investment perspective, we've got the patient perspective, innovator, and you'll hear Jodi's bio in a second, but she offers multiple perspectives as a former regulator, but also as someone who now supports companies in navigating the regulatory issues around digital health. And so I'm going to introduce everyone really quickly so that we could dive right in, but I do also want to note that we'll reserve about 10 minutes for Q&A. So first, to my right, we have Jodi Daniel, who is a partner at Crowell and Mooring's Healthcare Group and a director at CNM International, an international policy and regulatory affairs consulting firm. She leads the firm's digital health practice and provides strategic, legal, and policy advice to all types of healthcare and technology clients, navigating the dynamic regulatory environment related to technology in the healthcare sector. Prior to joining Crowell and Mooring, Jodi served at HHS, first as a lawyer drafting and interpreting the HIPAA privacy rule, and then as the founding director of the Office of Policy in the Office of the National Coordinator for Health Information Technology. Then we have Kym Martin, who is a business performance advisor at Insperity, who leverages her professional expertise as a business development leader and personal experience as a 4-time cancer survivor to help healthcare stakeholders understand and solve real-world patient and consumer challenges. With Insperity, Kym draws on her healthcare insights when advising executives across industries on employer risk mitigation, employee engagement, and best places to work culture. And we have Tim Wilson, who has focused his career on understanding and driving change at incumbent, broad-reaching industries that impact people's lives. Today, he is the CFO and strategy lead at Quil Health, where he brings years of investment and business building expertise across the energy and healthcare sectors to help drive Quil's innovation vision. And finally, Adimika Arthur, founding executive director for HealthTech for Medicaid, which is a collaborative that convenes payers, providers, policymakers, and entrepreneurs, and ultimately seeks to ensure critical new technology reaches Medicaid enrollees. For much of her career, Adimika has been a leader on planning, developing, and implementing strategies and initiatives to better understand and improve the U.S. Medicaid program. Thank you for being with us today. We're going to structure our questions to cover 3 general topics: innovation within digital health, outcomes from the digital health innovations, and then finally, kind of the environment in which digital health companies are operating. So we'll start with innovations. According to Rock Health, digital health companies have raised over $4 billion through the first half of 2019, and is on track to exceed its funding total of $8.1 billion in 2018, which was a record-breaking year. So I'd love to hear from the panelists, when we think about this digital health innovation landscape, what are the things that excite you? What are the trends that you think are most likely to disrupt healthcare delivery and access? And Adimika, if we could start with you.
Sure. So it's very interesting because digital health has been around for, I guess some people estimate about the last 12 to 14 years. And we had a little bit of a plateau. So the last IPO we had out of digital health was in 2016. And so there was a question of whether or not this bubble would burst, right? Is this a driver for innovation that is going to stall out? And we've seen in the first, couple of quarters of this year, the complete opposite, right? We've had several IPO exits, one of which was Livongo, who was one of our member companies, who focused specifically on, making sure that chronic disease management was looked at, but had a real interest in building from the bottom up, meaning that really wanted to look at all of the life cycles of patient populations, specifically those with Medicaid. And I think for me, that's one of the areas that is most interesting is how we have rapidly built this economic driver without thinking about the populations that we really need to serve. So when I talk to many health tech CEOs, it's often, I have an unusual name, so usually my name stops people because they're thinking like, how do I spell that? How am I gonna say that again, right? But then I say Medicaid, and that is another stop, right? And I think that if we don't think about creating solutions for more than just the employer-based market and the discretionary income related, whether it be to wearables or whatever, we're really missing out on a huge portion of the market. A little bit over 100 million people in this country are either on federal government programs and or could qualify but don't, or don't have the ability to due to immigration, felony, et cetera. So I think it's just something we're really seeing is holding innovators accountable, that our healthcare innovations are not being done in a vacuum, and that they're being done really thinking about all of us from a purposeful perspective and being accessible, equitable, safe, and that really that our voices need to be a part of the technology, that it's not just the business, but the business of healthcare involves the quality and duration of life.
Yeah, I would follow on to that. When you think about the digital revolution that's happening globally over the better part of 2 decades, health has always been a laggard, and there's good reason for that. It impacts our everyday lives. We want to make sure we get it right before you just start throwing things at people that are sick and in need. When I think about the trends that are really interesting to me, it's really about closing that gap between what we see in other industries, what people expect from financial services firms, from their banking. How can we bring some of that same equity, usability, personalization into healthcare that we've already seen proliferate across just about every other aspect of our lives, but for some reason is hitting up against wall after wall in health. So how do we innovate, publicly through private investment to really start to break those down and close that digital divide?
If I could jump in here, very interesting. I've been now doing this for 15 years, since 2004, when the first statement was made by government that we are going to try to promote the use of health information technology and electronic health records. What's amazing is for about 10 years, we're really talking about how do we get healthcare providers to use electronic health records, to use digital health technologies. How do we pay them to do that? Yeah. And what I've seen as a shift, just in the last maybe even 3 to 4 years, there's been a huge uptick, is that it's gone from what is the government requiring and pushing the industry to do to what is the industry sort of embracing and seeing as opportunity. And just in the last few years, seeing some of the large technology companies entering into this space and seeing huge opportunity to either improve diagnostics, improve consumer engagement, a lot more direct-to-consumer healthcare services. I think that has been a really stark shift just in the last few years that we've been dealing with digital health, where there's not just these ideas and promises and little bits of innovation, but where we're seeing a real embracing of innovation in healthcare by the traditional healthcare players, and more embracing of healthcare by the innovators as a place that they want to play and where they see that they can have an impact.
So I think from my perspective as the patient, I've been 36 years on this journey navigating this health system. So I know what it used to be like when primary care was actually primary care, which we've lost complete sight of, unfortunately. And what we still are not doing with innovation, although to your point we're making some strides, is human-centered design with patients,
Amen.
not with patients in mind.
Correct.
Right? I'd like to see a lot more head nods on that point, because that's what's, I think, in my opinion, and I know in my opinion, it's what's holding up our traction for innovation, to your point, Tim, because the solutions being developed aren't hitting the mark. And I have several examples and stories I'll share on the panel about successes of actually doing design with patients side by side from the concept of an innovative solution through to implementation, distribution, or however the channel is for that to come to see the light of day. So I'll talk more about that, but I will absolutely put a stake in the ground and saying that in my world is the one thing that's really dramatically holding back innovation across the landscape.
I couldn't agree more. I spent a good chunk of started my career in public health and then was a hospital administrator for the last 15 years. And I would say the provider community still struggles, right, with, whether and there was a last panel that talked, is it consumer, is it patient, is it participant? At the end of the day, it's people, right? We all want these services. And so how can we create an ethical overlay, right, to hold ourselves and others accountable, whether we be in the provider community, the payer community, the innovator community, the policymakers, which I do think they have a role in shaping the ethical framework around how innovations are adopted, developed, disseminated, and then continually evaluated. But I also feel like, because I hear this a lot, right? I live at the seat of many different stakeholders. I hear a lot, like the investment community, it's very hard to meet people's ROI needs, right? Their return on investment, it's such high stakes, it's a lot of money. But at the end of the day, the value of our life should matter. And the value of everyone's life should matter. And so when we talk about engagement of communities, engagement of people, that actually should mean all people. Because I do see a lot of health innovators selecting specific subpopulation groups where they can get a peer-reviewed journal article or they know it's going to be easy. But the reality is that doesn't translate to health care for everyone. And so sometimes we need to just learn basic lessons. I have a friend that uses the general things that we use all the time. And I was talking to somebody outside about this. We think of walking across the street as something, fairly easy to do, accessibility, right? And so every single one of our streets, pretty much in this country, have some sort of ability for you to go across the street, whether you're on a skateboard, you're riding a bike, you're in a wheelchair, etc. Now, some are more sophisticated than others, right? Some have the, marbled pebbling so that if you're blind, you can know the difference in where the curb is going to be. And some have the auditory control that maybe drives you a little crazy, that tells you, 3 seconds until you have to cross the street. But we all now have accommodated, this is what we're used to when we cross the street. It works for most people. Now, it's not perfect, right? But it works for most people. And how can we create what I call those digital crosswalks, or that sort of same thinking as it applies to healthcare and people's lives? That's where we need to go.
Yeah, I think specifically with the patient in mind and talking, I think to some degree about incentive alignment, right? So, I've seen a little bit of a change when you're speaking with the payer community versus the provider community, not as fast as I think any of us would like to see it. But I think one of the reasons you have the patient in mind versus the patient at the center of what you do is, for a company like Quil, we're not selling to the individual. We're not selling to the patient. We have to sell to a provider system, a payer system, a Medicaid managed care program, an MA program, and they may not always have the patient first of mind. I think we pay a lot of lip service to saying we do, and it is, but is there a way we could steer them here, or could we, do this over here, and is that really what's best for the patient? So I think as we continue to get better incentive alignment, value-based payment is progressing. But I think that'll be one key, and I think you're seeing people be a little more forward thinking, so finding those right design partners to be able to have the patient at the center, and building your company, your platform, your product, whatever you want to call it, around that will have hopefully a different result.
So I have to tag on to that because that's a perfect segue for one of my stories. So, and to Jodi's point too, in the last 4 years, I've had the opportunity to work with different organizations on their digital innovations. So in 2015, I consulted for a mobile app that was all about patient portability. And I was hired to just use the app for my purposes as a patient. Now, most of my data is not electronic. So what do you do for the patients who don't have all their data in an EHR or in portals? You got to think about that as innovators. I was specifically called in by the CEO to sit down with the designers and the developers to tell them why this was important to me, because they didn't know, right? So I had to educate them from why are you even doing this? Well, here's how you impact my life at the end of the day. That was one example. That was an app that actually got bought by Apple, or that was a company actually that got bought by Apple. I take all the credit. No, but what I will say though is
shame too. Then?
Yes, I'm totally jesting on that. But I did bring a colleague onto that project. Now I had the oncology story, which is a very complicated story for anybody in the room. You all know somebody who has had cancer. It's a very complicated experience. She had chronic pain, another complicated experience. All her data was in portals. Majority of it was redundant or had errors. So how do you clean that up? So that's another area of innovation, is getting clean data. So with that insight, and specifically working direct with their teams, they got a solution that actually got picked up by Apple and is now the basis for the solution they're putting forward for that portability capability. And I will say one other thing about finding the design leaders. WeGo Health is an organization that some of you may or may not know, but they are a large organization of patient leaders. They have about 100,000 patient leaders nationally. I was hired to help them when they were creating a digital platform that was to mirror like the gig economy. So patient leaders on one end of this spectrum could be hired as consultants to work with industry on the other side of the spectrum as the design leaders, so that those innovative projects, initiatives had greater chance of success. I sat in the middle as somebody who walks both worlds, patient community and healthcare community, and I did the matchmaking. I helped find the patient leaders for your project at Quil, for instance, right? And I would negotiate the fees, the consulting fees for the patient leaders, because there's no market rate for that talent. We haven't figured that out yet. And the patient leaders are so gracious with their time and talent, they don't value it enough. They need to get paid more. So I sat in the middle, negotiated 2 consultants to go for a one-day workshop in New York. They both had rheumatoid arthritis, and this global company wanted them to spend a day with their designers and developers to come up with a solution that would work with Alexa, specific to the RA community. The global VP gave me pushback on the day rate that I was proposing. And I was wrapping my head around the $5,000 investment it would have been for those 2 people to spend their day working with this global team. I finally got him to come around. He paid the $5,000, and at the end of that day, they had a working prototype. And that would not have happened, and this is their words, without the patients involved. Sure. So those are examples of what's possible and what's missing.
Well, and I also, I will say that that's a great story, and I hope that sort of investment actually happens in communities as well. And I say that because,
absolutely,
one patient story, and I learned this, very much being a hospital administrator, and you alluded to this earlier. One state Medicaid's program is just as good as the next state's Medicaid program, and we have 56 different ways that Medicaid is done in this country. But representing the lives and the needs of individuals who are poor, disabled, genetically unlucky in this country looks very different. Last night on my red-eye flight here, I sat next to this great gentleman whose son is severely autistic, and they live in the state of Maryland. And while he has a master's degree and his wife has a master's degree, and they, he has a great job, they're able to utilize resources through Medicaid to better their child's life. That story is very different for many other people across this country. And I think that thinking about the diversity of the patient population is really important. And that's where I think, as we look at social determinants of health, we look at like the fundamentals of what I consider to be public health. Is really how can we get communities to be involved in their own healthcare journey, right? Whether it be with their local community or district hospital or public hospital or private hospital, or their own plans, right? And how do those sorts of pressures from the provider community, the payer community, and the policymakers really like shift and turn how we think about health? Because to me, health is a holistic thing. It's a right that all of us deserve to be a part of this process, not that it's only garnered or given to those who have the ability to speak for themselves or have a larger voice.
And Tim and Jodi, representing the health innovator perspective, I mean, what are the barriers for companies to really making what Kym described more the norm rather than the exception?
Sure, yeah, I can start. I love all those comments. When I think about the real power of digital health, to me it's the ability to personalize. We could create a different type of care for every single individual in the country because you can do it digitally. I can connect you to these 3 services that may be relevant for Kym but not relevant to you,
Sure.
and have a very unique experience that looks like me, feels like me, and that I can trust. But you also talked about how you go from Maryland to North Carolina to Arizona, and those Medicaid plans are totally different.
Sure.
And then even within one of those states, every provider system is different, and they may or may not be connected. So I think it's the fragmentation is really a difficult problem to solve, because you can create this great Alexa app for rheumatoid arthritis, and any other industry would say, okay, go, great, scale it, you've done it. It's just not the way in health. There's so many other nuances that make that difficult. So it really is this holistic public policy, private investment, and incentive alignment that needs to come together. How that comes together, I don't know. We're trying to just start in one place. But it really takes everyone kind of getting in line, speaking with each other, and I think operating with trust first to get that ball rolling.
And I'll just say that's not unique just to Medicaid. I mean, you spoke a little bit about how this digital health journey started with electronic health records. This is still the major pain point in most hospital systems, most physicians that you speak to, most physician extenders, nurses, payers. I mean, everyone really, it falls down to the same issue around every single system. My system is different at this hospital that's 0.3 miles from that hospital. So I think it falls beyond our policy-related walls, but
Well, I'm going to go back to the policy.
yeah, please.
But I agree. And I think one of the challenges is there's the variability, which I think is a huge challenge, right? And so when somebody's trying to scale a new innovative technology, it's not always going to work or not work the same way in every system or in every state and every community. But I think the other big challenge is that the policy landscape, even at the federal and the state level, is very dynamic and changing. And a lot of the regulations were developed at a time before digital health. So how the rules apply in this new innovative environment is not always clear, and often they don't necessarily fit well. It's a little bit of a square peg in a round hole. So what happens is as I've been working with innovative technology companies, they're trying to figure out how they have this great idea to improve the diagnosis of a particular disease or to help engage patients or whatever the issue is that they're trying to address. And then they're literally jumping through hoops and trying, kind of not going a straight line, but going zigzag to try to get to the outcome, which is the right answer and a good service and a good product for consumers, for providers, whatever, but they can't get from point A to point B because they're sort of trying to navigate all of the policy landmines. On top of that, all of the rules are changing. So we've seen new changes in CMS reimbursement for virtual care and remote patient monitoring. We're expecting proposed changes to the HIPAA rules. We're seeing state and federal policy proposals and legislation on privacy. We're seeing proposed changes to the fraud and abuse laws. We're seeing changes in how FDA is regulating digital health technology. this is all this year. So if you're an innovator or an investor, or even an innovative health system who's trying to do right by your patients, knowing what the rules are is really hard because one, they don't always fit, and two, they're changing right beneath your feet. As soon as you think you've got a solution, well, the rules might be changing, hopefully to support innovation, but the uncertainty is really challenging for a lot of organizations that are investing in trying to provide innovative technologies in healthcare. And so a lot of times we're trying to help folks play risk management and risk mitigation strategy. What's the best way to get from point A to point B without tripping on too many landmines, as opposed to just, this is the right thing to do, let's go that way. What I think is really challenging, and we can get to this maybe a little bit later, is how policymakers deal with that, because the reason that all of these laws are changing is to try to make it easier for innovation. So there is this trade-off between certainty and trying to get out of the way, and I think a little bit of a fear, and I hope I can talk a little bit more about this, about what happens if policymakers go too far, so that they promote innovation but don't necessarily think about what's best for the patient, how to protect privacy, how to protect safety. The example that was just given at the keynote speaker about the Boeing 737 MAX airplanes falling out of the sky. It took 2 planes to fall out of the sky before folks realized that the FAA hadn't really looked at the software that was key to that technology. Yet we're doing some of the same thing with the FDA and their policies on enforcement discretion. So it's great, it promotes innovation, but what's the right balance between innovation and consumer protection? And I think that that's a really hard line to walk for regulators.
And I think certainly FDA is probably the easiest example where there's risk to patients, but I would say increasingly when you think about digital health tools and the amount of misinformation that's out there, vaccinations especially are probably one of the hottest topics. Hey, it's great to learn. You can learn a lot of things digitally, but misinformation can pervade pretty quickly. So another thing, to the degree you start bypassing some of the traditional routes to medicine or care, what are some of the unintended consequences that you may not know if you try to accelerate things?
And there's entire industries that are being built around that, like digital therapeutics. It's a great example, right? And so, how do we rationalize this in a way? It's very challenging, and interesting.
That's a great example.
I mean, we talked about the policy, the uncertainty around the policy environment, but can we also talk about the reimbursement environment? I mean, Tim also talked about value-based payment, but can we, I'd love to hear each of your perspectives on how the reimbursement uncertainty is also playing a role here.
Well, I'll start with one thing. So just on last Friday, CMS put out new physician fee schedule rules that where they are trying to improve reimbursement for virtual care and telehealth, remote patient monitoring, chronic care management. And I think they've actually made great strides. And what I've seen is the number of organizations that have come to me to ask for information about how those reimbursement codes work has been staggering, which really suggests to me that the reimbursement changes are helping to promote innovation. Now, there's still some challenges with them. Some of the codes are time-based, and so if you have really efficient innovation, you can't get reimbursed. So there's sort of a disincentive to adopt more efficient technologies because you might not hit the time threshold. So there are some challenges to the reimbursement strategies, but I think the reimbursement strategies of CMS and private payers will have a huge impact on the changes in leveraging technology to improve care. Same thing with value-based care. I agree with Tim's comment, and I'd love to hear more of your thoughts on this, but I think that shifting to paying for value as opposed to fee-for-service will be game-changing in providing innovative solutions that work for patients, that provide better care, that provide better outcomes, and that also address some of the inefficiencies in our system and the complications that payers, providers, and patients have to deal with in navigating through through providing the best care to individuals.
Yeah, and I was just going to say the journey for value-based care has been a long journey.
Yes.
I'm just going to be very honest. It feels a little bit like a monopoly board.
Yeah.
And, you take 6 steps forward, then you pull the wrong card, you got to go 8 steps back. And I think that is because in our provider communities and in our payer communities, we're still incentivized on a fee-for-service market. So we are playing this weird blindfolded game of, ping pong. It's really challenging to understand where the ball is going if you can't see it coming your way. And it's very hard for you to be incentivized on one end and disincentivized on the other, but yet incentivized. And so I think we just have to grapple with some of these very hard choices we are throwing more money and more money and more money at a system that fundamentally has big, huge fissures and cracks, right? Like I'm from California, so I could talk all earthquake monotone for a while, and it might be fires soon. But I think that it's really important for us to recognize that until we fundamentally get down to what is our value system based on? Is our value system based upon the clinician? Is our value system based upon the people? I think any of us in this room, if you have a family member who's in the hospital, what do? You drop everything and you go to their side and you try to go and, in the best way that you can, best navigate their care, right? And that's what all of us do. That signals that our system is a bit on the broken side, right? And so I think the regulatory changes are great, but if we don't fundamentally get down to the brass tacks of what we're trying to build in this country, no amount of innovation is going to upend that, right? We're going to continually be on this cycle. This value-based care journey has been a longer journey than the digital health journey.
Yes.
Well, I think we have so many competing interests.
Oh, sure.
Right? We're all competing for different outcomes, and we can say, and a lot of companies do say, we put the patient at the center. Look at the panel. This might have been by design, it might have been by default, I don't know. But when I saw that, I thought, okay, we do say we put the patient at the center. But fundamentally, companies can't often do that because of the reimbursements, because of the providers, stakeholder interests, the policymakers, influences. So it sounds good in theory, but in reality, it's really not the model.
And what we've learned is it's until you're the patient, right?
But even then.
But
even then.
Yeah.
Cerner's CEO, when he got sick, when his wife got sick, no amount of money in the world saved either one of them. So, and he had every bit of access to every resource available, including money, but resource across the system, and he couldn't get it to work. And he was part of the problem, right? So there's the irony in how that played out. So I'll leave it for there. I do have something though.
I think I'll maybe just add one thing to the reimbursement. I think it's really important, it depends on which lens you look through, right? So how you think about reimbursement and the mechanisms for getting paid is much different if you're a provider system versus you are a traditional insurer or a self-funded employer or someone selling into that space, which is where Quil is. And you talked about all the money that's being thrown into healthcare, and I actually think it's kind of an unintended consequence of some of the incremental reimbursement mechanisms.
Yeah.
Because as soon as CMS decides that they're going to reimburse for one more thing or something like that, there is a rush of money to create companies to go exploit that code. And it adds to the fragmentation of the system rather than making the system overall more innovative. And so that's a tough problem. I'm not sure how you solve for that. Quil, we believe you have to drive deep value, and chasing codes isn't a way to build a sustainable business. People have made a lot of money off of doing that, but that's not necessarily a long-term sustainable value across the entire ecosystem, in my opinion.
I think that's really interesting because we're also seeing so many technology companies that are starting to, or even healthcare providers that are starting to find different ways to provide access to different kinds of services and care outside of the traditional environment. So you see telehealth organizations, you're seeing retail pharmacies that are providing care, you're seeing, which will lead to more fragmentation in care, but they're trying to address the problem of convenience and avoiding the reimbursement challenges to getting the right care to an individual. So I think the reimbursement problem has led to other problems where we see, Amazon Care, for example, right? They're going to be providing direct care for their employees outside of the traditional health plan and healthcare provider infrastructure. So I think that the problem of reimbursement and the fragmentation is leading to more fragmentation as folks are looking for innovative solutions to providing the right services to the patients when they need them.
But we also could be losing populations of people as we do that. And I think that's where my biggest concern comes in. How HealthTech for Medicaid actually started is that the more that happens outside of the traditional system, right, really depends on, I mentioned earlier, I think of healthcare in a circle, but if the circle is only a rainbow, if only the top part of the system gets to work well or gets access, we're screwed, right? If that top part is employer-based coverage and people who have the discretionary income to play in, what are we doing with the bottom part of that? It's like a rainbow and a smile. Both are good, positive things, right? But if the smile is always screwed in the system, we are further removing populations, huge populations in this country, from basic care, right? Because we're upending it in a completely different way. And it sounds interesting when you're saying, populations of people, right? And some people think, oh, that's not that big. We have over 75 million people on Medicaid in this country. That is the size of France, right? Like, that is that big. And to think about those individuals, or, us, I should say, right? Like, to think about us not providing access to that large of an entity it's a crime. It's not okay. Yeah.
Thank you.
Yeah, I think if you read the news, the innovations that are being highlighted are all around your rainbow.
Yeah. Sure.
And not around the smile. So when you think about centers of excellence models, integrated care clinics, that's all benefiting mostly those of us on employer insurance.
And the lobbying entities, right, that help inform the regulators are those individuals who can actually pay for it. And it is really, it's a bit of a criminal job in the system, right? When we all think of health, or when most of us should at least think of health as being something that we all want to participate in. We all want, for ourselves, for our families, for our neighbors, for our children, the ability to live a quality, high quality, longest duration life that you can.
Now we've got under 10 minutes left to the session, and I want to open up the question, open up a Q&A for the audience, and hopefully there's a mic floating around. I see a hand up there. Thank you.
Okay. Hi, thank you so much. My name is Steph Guerra. I'm a AAAS Science Policy Fellow at the VA. My question is related to value-based payment plans. There's been some studies of the new Medicare programs that are on value-based payments, but they haven't really lived up to expectations in terms of quality of care or patient satisfaction. So my question is, value-based payment plans and care is sort of has a lot of promise and everyone talks about it. And I'm wondering, do you think that we just need more time to see the effects of these plans that Medicare has come out with, or are there other actions that need to be taken in order to make sure they live up to that promise?
I mean, I can take the first stab, and please tell me I'm wrong. I actually see it as not enough. So when I look at provider systems that are under value-based care, it's such a small part of their overall revenue that they're not really treating it any differently.
Correct.
They're treating it like a regular fee-for-service and hoping that they make more, that kind of the math works out for them. So I think you need to make them feel it a little bit more and say, hey, don't put 5% of your revenue at risk, put 25%, put a third of your revenue at risk, and stand behind your doctors and the quality that they're doing. And that takes some time, and there are real challenges to that. But I think it's, you're going to find people that do it really well because they've changed the way they're thinking. But I think when you look at the aggregate in the population, it's just not significant enough for people to really change the way they do business.
Yeah, and I think the VA is a great example. Like, I think in closed systems, it's a little easier to do, right? Because you have a semblance of control, right? Mm-hmm. And so I couldn't agree more that the market size is incredibly small, and it's actually rushed a lot of people to go into the MA market because they feel like that's going to be their big break on making making large sweeping value, right? Like from a financial perspective, right? And so the incentives are upended. They're backwards. And so I think until we start to look from a population perspective, right, where we are all incentivized to play, I think it's going to be really challenging. I mean, you've got to have an engaged group of clinicians. You've got to have really well made out care pathways. You've got to create services that meet people's social needs, and those needs are beyond having a case manager call you. They are housing, they're food insecurity, they're significant issues, which means, to me, like, that's where the infrastructure in this country needs to adjust so that our health goes back to a holistic perspective. And I think it's just going to, unfortunately, we're mixing value-based payments and MA plans in the same bucket. But they were never intended to be that way. Value was for everyone's value of care. That was the intent.
I think I agree 100% with what you were saying. And Tim, your point about there's not enough at risk. Fee-for-service is, you're asking people to change the way they've done business for their entire careers, for their entire life of that organization. You're not giving them a huge incentive to do that hard work. And fee-for-service actually pays very well, right? So why would I change if I'm only a little bit at risk, right? So I think it is the financial incentives. I think you'd have to change the financial incentives significantly to get people to do something in a different way, fundamentally different way, not just tweaking around the edges, as well as to have the value that they can get, the money they can earn from value-based care. Kind of get closer to what they were earning before with fee-for-service.
Yeah, right now it's a marketing ploy. I mean, in my mind, it's like the feel-good stories in the newspaper around how we're doing value-based care versus truly investing in value-based care.
So how do we get there?
We all got to get in a room together. I mean, this is it's part of the challenge is we've got to have very clear strategies in my mind about what our value is, like defining that value and actually. And I think you just said it, right? We need to have financial incentives that are aligned, and we've got to figure out how do you, and there are other industries that have done this, right? Like you've mentioned, right? We've had to upend other industries that just didn't work any longer. Look at the banking industry. Look at lots of different industries. We may have to get there with healthcare. Like, how do we kind of unravel the system we have today and re-knit it back together in something that's a little bit more meets the modern day needs?
So one example of another in support of this, because we're waiting for this monumental shift in the business model of healthcare, there are unique partnerships now starting to take place between state agencies, public utilities, and nonprofits. So there are other organizations trying to really help ensure that patients get, in one example, in Maryland, in January of 2018, Maryland passed legislation called the Critical Medical Needs Program. And it is designed for the state of Maryland, the public utility companies, and this nonprofit Cancer Foundation. The CEO was the driver behind all this, was to make sure any patient who had a critical medical need, didn't have to be oncology, could have been diabetes, could have been any other host of illnesses. The key social determinant of health they found to be most impactful to keep patients engaged and alive was keeping the power, the lights, and the heat on. So the state of Maryland has grants, guaranteed grants, to fund these heating bills and electric bills for every resident who qualifies for critical medical need. She has navigators who facilitate the process on behalf of the patients because they don't know how to engage with the agencies. And since, I have to look at my notes, from 2015 to 2019, there's been a 70% reduction in terminations of power for these patients who would otherwise not be able to afford it. And that might mean they can't keep their medications, refrigerated, they can't report into their doctor, they can't call for help, So that's one example that could easily be replicated. If Maryland can do it, there's no reason the other 49 states can't. So I give a shout out to Cindy Carter at Cancer Foundation because she was mad driver behind trying to pick up some of this slack as we wait for the value-based care model to kick in.
Do we have any more questions? Fortunately, we're coming up against time. Thank you so much to the panelists for this great discussion. You made my job easy. I could listen to you guys all afternoon. But I think what we've heard today is that in order for digital health innovation to deliver on its promise, there's a lot of work still to be done. Sure. Right, to achieve equity, access to innovation, integrating patient perspectives, policy clarity, financial incentives. But I think what we also heard are some potential models, and Kym, thank you so much for sharing your stories that can really pave the path forward. So this concludes our session. Thank you.